Hi, I'm Dave Fresnel, the editor of Diagnostic and Interventional Cardiology magazine, and I have with me to talk about the evolution of mitral valve repair at the University of Colorado, Andreas Brieke. He is the Director of Mechanical Circulatory Support and a heart failure physician, and you were the site PI for the COAPT trial that was presented at TCT 2018 earlier this year, and many people said it's a paradigm shift in heart failure care.
I think it is a paradigm shift in patients who obviously suffered from long-standing heart failure with dilated ventricles and have secondarily developed mitral regurgitation. Because for the first time ever, we actually were able to document that we actually can alter the fate of these patients, decrease hospitalization, improve mortality, or make them live longer by actually deploying this mitral valve clip in the setting of really good underlying guideline-directed medical therapy. And that has never been shown before. And in addition to that, the numbers we actually produce, meaning the numbers needed to treat, are really unbelievably low. So this is actually a therapy which is, I think, a game changer for these patients. Though it obviously has to be seen in the context of these patients. The enrollment criteria were rather strict. The pre-COAPT requirements that patients get into this trial in terms of a medical therapy was probably one of the strongest, overlooked by the steering committee I've ever seen. They actually pointed that out very explicitly in the manuscript. And I think this is going to be the point of discussion moving forward. Is this for this small population we actually enrolled, because it took 6 years to actually get this whole trial done, or can this be more generalized? And I think that question is up in the air, and that will be hopefully decided soon.
And tell me about the cases that you had here at the University of Colorado.
Yeah, so our cases, number one, where do they come from? The minority actually were coming from our own center. I mean, me and my partners in the heart failure group, we supplied, I would say, about a third of the patients we enrolled finally in the trial. The rest were really coming from our network, from our referral group. We're working very intensely here in Colorado, and they have worked with our group for years and years when it gets to mitral regurgitation clipping in degenerative mitral regurgitation. So that has been an effort for years, and this was kind of the basis where these patients then came for. And once they learned that we have something to offer for these patients who really have no options, because we are not surgical candidates. That was obviously one of the mandates on COAPT. They were sent in here, and that has worked very well, and I think we have built even a better relationship with our community and drawing even more referrals for this particular part, or my second job, basically, being a heart failure physician and a transplant cardiologist. Some of his patients are better served with this kind of therapy if they're even beyond COAPT and couldn't really be enrolled in the study anymore. You definitely should treat these patients with great medications. There are multiple patients who I ended up not enrolling in COAPT because with a little bit of more tweaking of the medications, they actually got better. They lost their mitral regurgitation, was down to a mild to moderate, and then obviously they were not enrollable in this trial because they really did not need this anymore. I think this is the message of COAPT. You should do this very vigorously to actually do the right for the patients. And I mean, if you look actually at the manuscript and see how little medication changes were done during the COAPT trial, it's just a testament of what was done beforehand. They were optimized, and there was nothing else to do for these patients. And there, obviously, the alternative trial from France was quite the opposite. They started treating while they enrolled in the trial. So this is one of the major differences between the two trials. And yeah, medical therapy does work in a subset of patients, and some it doesn't. And in some patients, the heart is basically too far gone that even clipping them would probably be detrimental. And I think there will be some sub-analysis out of COAPT showing exactly this, that too far gone, you cannot clip them. This is just a myopathy driving the whole disease process in this patient. Well, other avenues for COAPT, I think it's going to be an interesting development maybe in the next couple of years. And whether we should actually deploy this therapy premature. What if the ventricle is on this size and there's moderate MR? Are you going to help patients with this? I see something coming down the pipeline that maybe even a trial will be actually pushed forward. So we don't let this get out of hand, because in the end of the day it feeds on itself, right? I mean, you have this myopathy, the MR is secondarily, and then eventually the myopathy, because of a volume shift in this ventricle, will just get worse and worse. And yes, there's a point of no return, we do know that, but what if we actually intervene preemptively? Again, COAPT does not support that strategy, but some people will probably think, well, this might be actually the opener for this kind of approach to this, which would require a new trial.
Well, thank you very much for your time.
Thank you very much for getting.